All right. Hi, everyone. I know you're working on getting your lunches. Thank you so much for being here for our Grand Rounds talk, and thank you to the Grand Rounds Committee for spotlighting this topic today. Today, we're going to be presenting on innovations in family medicine abortion care with a focus on education and implementation in diverse primary care settings. I'm Ying, I use she, her pronouns, and I'm an associate professor in our Department of Family Medicine. I co-lead our Won't Go Back initiative, as well as our Project ECHO, focused on expanding medication abortion education in primary care. I'm going to pass it to our panelists as well to introduce themselves. We'll go to Rory first because you're on the screen, maybe.
Okay. Hi, everyone. My name is Rory Tito. I use she, her pronouns. I am the Associate Director of Training and Education at the Reproductive Health Access Project. And I'll pass it to Anna.
Hi, my name is Anna Fiastro. I'm a research scientist in the Department of Family Medicine, and I co-lead the Won't Go Back initiative with Dr. Ying Zhang. Excited to be here. Debbie, do you want to go next?
Yeah, hi everybody, Debbie Stulberg. I'm a family physician, chair of the Department of Family Medicine at the University of Chicago, and I co-direct the Expand Mifepristone Learning Collaborative, as well as being a proud member of the Repro TLC board, and so I will toss to Latona.
Hey everyone, I'm Latona Giwa. I use they or she pronouns. I'm a nurse, doula, and IBCLC lactation consultant, and I'm the executive director of Repro TLC. Thanks.
Thank you all. We're excited to present this panel from around the country, and we'll jump right in. Thank you so much. So we don't have any financial disclosures. I do want to acknowledge that while you may hear some gendered language during this presentation with female and women use, we do recognize that people across the gender spectrum need and access reproductive health services. Anyone with a uterus and capable of pregnancy may also need and access abortion care. So I wanted to provide some historical and social political context for abortion in our country, as well as get us to where we are now. Historically, before the 1800s, in our country, abortion has been legal and common until quickening, which is also known as the time in pregnancy when individuals start to feel fetal movement. That's usually around 18 weeks of pregnancy. In the past, abortion was majority provided by skilled midwives, nurses, community attendants. Although these folks were healthcare providers and unlicensed, they were very much trusted in their communities and served broad communities around the country. Interestingly, before our modern medications that we use for abortion were available, things like herbs and plants and other abortion procedures were used to provide this care for individuals. On this slide, you'll see a picture of pennyroyal, which is an herb. It's a species of mint that is an abortifacient and has and continues to be used to regulate the menstrual cycle. And here is a picture of highlighting the commercialization of abortifacients. This article is from the late 1800s, where pharmacists, who used to be known as druggists, would provide things like female pills, and here pennyroyal female pills that would help with menstrual regulation. And in the small print, which you can't see, this says pennyroyal female pills can be used to restrict menstruation when suppressed by any cause, including early pregnancy. So interestingly, like social media has historically been a good way of access for individuals to access this care and information. Sometime in the mid-1800s, when the American Medical Association was founded, there really was a shift in our country from provision of abortion by midwives and community attendants to physicians. And so the AMA originally and initially, the membership was largely male physicians and white male physicians. Women and Black healthcare professionals were excluded from the AMA. the AMA really worked to shift sort of the hierarchy of the medical profession to physicians as sort of knowing best. And also they worked to push state lawmakers as well to change change the idea that life begins at conception rather than at quickening, and also worked on abortion bans across many states. So we saw in the late 1800s, 40 anti-abortion statutes were passed between the states. At the same time, the specialty of OBGYN emerged. And here on this slide, you can see a picture of the monument in Alabama titled The Mothers of Gynecology. This highlights 3 enslaved women, Anarcha, Betsy, and Lucy, who were experimented on by who used to be known as the father of gynecology, J. Marion Sims. While he was responsible for bringing about some of the modern instruments we use today in gynecology, he also did perform surgeries on women who were anesthetized, and especially enslaved women. I bring this story up to sort of recognize the history and sort of what we wrestle with in our medical profession, the history of lack of consent for reproductive health care for certain communities and individuals, as well as experimentation with research of some of our modern contraceptives even, and the reasons why some individuals in certain communities may lack trust in the healthcare, in our healthcare field, and continue to seek care outside of healthcare, including things like self-managed abortion and self-sourcing medications for abortion, which continues to this day and is very safe, as we know from recent literature. So in the early 1900s, we saw abortion banned in the country. Despite that ban, millions of women continued to get abortion care and need abortion care. In the early 1900s, we saw a rise in maternal mortality, with 17% of birth-related deaths attributed to illegal abortion. Around the same time in the 1960s, there was a huge rubella epidemic, which caused the death of millions of Americans in the US, and also contributed to thousands of miscarriages, as well as severe birth defects. With this rubella epidemic, as well as the rise of maternal mortality, we saw more support for the reproductive rights movement. And we also saw the public outlook on abortion shift to providing sort of more support for safe abortion care. And then, as you know, in 1973, the Supreme Court ruled on Roe v. Wade, codifying the federal right to abortion. Despite the federal right to abortion, abortion has effectively been inaccessible to a lot of communities, especially people who are low income or living in poverty. The Hyde Amendment has been a big driver of that, which was passed a few years after Roe, and continues to prevent federal funds from being used to pay for abortion care. And then in the 1990s, another big case, Planned Parenthood versus Casey. Although it upheld Roe, it also sort of created the undue burden test for states that continue to sort of chip away at abortion access through state level restrictions. So the undue burden test was that state level restrictions were lawful as long as they didn't create an undue burden to individuals seeking that care. And then we get to modern days, where recently in June 2022, a lot of us were left reeling after the Dobbs decision, which overturned Roe, the 50-year precedent of having the federal right to abortion in our country was overturned. And now we have states regulating abortion care locally. This map here is from the Guttmacher Institute, which does a lot of policy research on reproductive health in our country. It's a good visualization of the patchwork of abortion laws and restrictions around the country. Here, the deepest orange represents the most restrictive states, some of them having banned abortion already, and then the deepest purple representing states that have the most protections for abortion care and access. Despite these restrictions and bans, we know that people continue to get abortion care around the 50 states. With bold clinicians in access states who may be protected by shield laws in those states, they're able to mail medications into restricted states and banned states and across the country. More than 300,000 medications were mailed in 2025 for medication of abortion, as well as we know that, as I mentioned before, a lot of individuals are self-sourcing these medications as well. So that gets us to medication abortion, which makes up the majority of abortions in our country, about 60%, or a little more than that, of abortions are medication abortion. And then a quarter of abortions are provided by telehealth medication abortion. And that number is rising, especially since the pandemic and some of the FDA restrictions on mifepristone were changed during the pandemic. We know the mainstay of medication abortion in our country is mifepristone and misoprostol as a combination. We know these medications are very safe and very effective for abortion care. However, mifepristone, although safer than Tylenol and penicillin, is regulated by the REMS. That stands for the Risk Evaluation and Mitigation Strategy. This regulation is something that the FDA places on dangerous medications like chemotherapy and opioids. And this prevents mifepristone from being prescribed widely to any pharmacy. And then many of you may have seen mifepristone in the news recently with Louisiana suing the FDA, trying to create more restrictions for mifepristone and basically prevent it from being mailed or provided by telehealth. Thankfully, with modern research, we know that there are alternatives to mifepristone and misoprostol for medication abortion provisions. And so those would be available and are available in the setting if mifepristone becomes limited in the future. And so you may be wondering, like, why this history? What does it have to do with primary care and family medicine? And I would say it has everything to do with family medicine. Family medicine, with our history in counterculture, our rooting, our discipline in social justice and whole person care. You know, primary care and family medicine is at the front line of all reproductive health of people around the country. We are in the most remote places. We're in rural places, serving our communities, serving individuals within their families and communities. This article here was written by a few family doctors in Scientific America and really was a call to action for primary care providers to help safeguard abortion. We're well positioned to provide equitable access to care as well as the continuity across the reproductive lifespan. Less than 3% of family physicians around the country currently provide abortion, but you'll see from some of our panelists and the innovative programs they'll talk about that we're really trying to change that number and mobilizing people around the country. Even in places where there's restrictions and bans, primary care can provide accurate information, patient-centered options counseling, the pre-care and the post-care after abortion care as people return to their communities as well. And you'll see on this slide a few of the organizations that have been supporting family medicine for years in education and training. And we have two of them here today with RAP and Repro TLC. So without further ado, I'll pass it to Rory.
Thank you so much, Ying. Hi, everyone. Again, my name is Rory Tito, and I work for the Reproductive Health Access Project, also known as RAP. We are a national nonprofit that trains, supports, and mobilizes primary care clinicians to ensure equitable access to sexual and reproductive health care, including abortion. And Ying just touched upon some of these, but I'll go a little bit more in depth. And here at RAP, for many reasons, we believe that people should be able to get abortion care where they get the rest of their health care. Abortion falls within the scope of practice for primary care providers and does not require advanced technical knowledge or skills or expensive equipment. Primary care clinicians are purposefully located in areas to best serve their communities and provide key access points for care, especially in rural areas or other settings with transportation challenges. Referrals can sometimes cause delays, which can result in people getting their abortions later in pregnancy, which can oftentimes be more costly or complex. Seeing patients in-house also results in better continuity of care, and it's found that many patients prefer to get care with their PCP who they know and trust. Access states like Washington have long been safe havens for out-of-state abortion seekers, and since the Dobbs decision, there has been an increase in people traveling across state lines to seek abortion care. So even in states where people historically say, like, we have good access here, there's an abortion clinic downtown or close by, a lot of those appointments are now being used up by people who are traveling from out of state. So it can be a little bit more challenging, even in access states, for people to get care. And lastly, when we treat abortion like any other healthcare service and when it can be accessed like any other healthcare service, it can greatly reduce the stigma that we know surrounds this care. And despite these reasons and the generally straightforward clinical nature of MAB care, there are often barriers to providing this care. Not every organization will face these barriers, and some may overcome them more easily than others. Here at UW, champions throughout the system have done an incredible job of reducing these challenges on a systems level. Sometimes there can be a lack of buy-in from leadership or staff, which can make it difficult to move MAB provision from an idea to reality. This lack of buy-in can often stem from many places, but it's often there's going to be a fear of staff, community or political backlash, and other concerns that are often fueled by stigma or misinformation. There are some legal or administrative burdens, like Ying mentioned, the FDA REMS, but luckily in Washington, there aren't any state laws that make it more difficult to provide care. And while some clinicians graduate residency with training in abortion, many don't. Additionally, some level of training is often needed for clinical and administrative support staff to feel comfortable working with MAP patients. And there are often some clinical systems that need to be figured out, like after-hours care or referrals. There can be some financial challenges in states where you can't bill for abortion. However, in Washington, Medicaid and private insurance are both required to cover abortion. Staff sometimes have safety and security concerns. These should be approached as valid concerns to address, but know that safety and security incidents for primary care sites providing MAB are quite rare. And for organizations with considerable federal funding like FQHCs and Title X health centers, there are challenging cost allocation systems that need to be set up to separate abortion costs from federal funding. So taking these challenges into account, practice change for abortion can really be broken down into two categories. Systems change, which involves clinical, operational, and administrative considerations, and culture change, which involves more work around values, beliefs, and communication. So what does MAB implementation look like in action? Sites that want to integrate MAB into care should identify champions who will move the process forward. It can be really helpful to have a multidisciplinary team. Some people may focus more on the administrative tasks, while others may focus more on things like clinical trainings and getting protocols set up. You'll need to spend some time building buy-in among staff and leadership, have conversations, do trainings, answer questions, communicate the change effectively, and speak to people's shared values. Without support, this process will be extremely difficult. You'll need to figure out your clinical workflow, address any financial concerns, and make sure your administrative and operational systems are good to go. For example, like getting EHR templates set up and ordering ready. You'll likely need to do some training. It's a bit easier to figure out what training is really necessary once you figured out your workflow and who will be involved in care. And there are a ton of free training resources available online, which we can share. So you don't need to recreate the wheel when it comes to training. And lastly, I would encourage those of you who are interested in providing MAB care to get connected to supports, resources, and others who are doing this work. This process can sometimes be frustrating, and it can be really helpful to have others to go to with questions and challenges. And you will hear a bit more about the support available at UW later on in this presentation. And we've learned many lessons throughout the years of providing technical assistance to implement MAB at various organizations across the country, ranging from large academic medical centers to small community providers. One, you need a sustainable, multidisciplinary team of champions committed to implementation. Success is often impacted by staff stability and champions' proximity to power. Engage leadership and staff early and communicate strategically. Different audiences might need different messaging, so figure out what's important to people you're speaking to. Maybe it's safety and efficacy data. Maybe it's something more emotional, like a story about a patient you wish you could have provided care to, but couldn't in the moment. It's important to note that high-level leaders can often stop progress or push it through. You should create a system for accountability, like monthly check-ins with your team, and plan out an implementation timeline. Just don't be discouraged if this shifts. This work often takes longer than it feels like it should. And focus on what you can when you can. I've worked with sites where one person in leadership is preventing things from moving forward. So in the meantime, champions focused on things like options counseling training, refining the referral processes, and strengthening pre and post-abortion care. And lastly, don't recreate the wheel and find support in others. If you're experiencing a challenge, chances are someone else has successfully navigated it before. If you need a resource, chances are it exists somewhere. I'm always happy to answer questions or help make connections, and you'll hear more about additional resources and programs for MAPP implementation throughout the rest of this presentation. And lastly, I just wanted to highlight some of the other ways you can get connected to RAP, and you can learn more about all of these on our website, reproductiveaccess.org. So we have our free resource hub of patient education materials and clinical tools that focus on contraception, abortion, and early pregnancy loss care. Our patient ed materials are evidence-based, easy to understand, available to download, and translated into many languages. You can also sign up for Pearls and Insights, our succinct and actionable monthly articles that focus on contraception, abortion, and early pregnancy loss care. If you're looking to get involved in advocacy and connect with other clinicians interested in sexual and reproductive health, you can join our Reproductive Health Access Network's Washington cluster or one of our professional cohort clusters for advanced practice clinicians, emergency med providers, or internal med clinicians. We also do have a reproductive healthcare and advocacy fellowship. It's a year-long intensive clinical training program that equips family medicine leaders with the skills needed to provide, teach, and advocate for access to equitable and person-centered care, especially in a primary care context. And now I'll hand it over to Deb.
Thank you. Rory, thank you for everything that RAP does. And hopefully what I'm going to share about our program Expand Mifepristone is building on a lot of the themes that Rory shared. So if you can advance the slide. So given all of the benefits, why are family physicians and other frontline clinicians not providing medication abortion on a more regular basis? And the background research that Liz Janiak and I did with a group of medical students and research teams at the University of Chicago and the Brigham and Women's Hospital kind of, I think, put some provider voices to exactly what Rory was talking about. So one of the common themes is financial repercussions or really fears thereof. So this one interviewee from our original research said, we don't receive Title X fundings, but we do receive federal funding from community health centers. And even though that funding doesn't directly prohibit abortion care, it feels like it's moving in that direction. So this interviewee was pretty well informed in knowing that the Hyde Amendment does not ban all abortion care in FQHCs, but still the fear associated with the threat to federal funding was preventing them from implementing medication abortion in their or any abortion care in their practice. The second, over on the right in the pink, is the logistical reasons that are closely related to the REMS restrictions that both Rory and Ying talked about. So this interviewee said there's a myriad of logistical reasons that it was challenging to incorporate like right now. Like even if we're just talking about medication abortion, not procedural, logistical things of just having the medications around, the volume of use being low, and how often would you be needing to restock the medications for expiration dates? So we don't think about this with most medications we prescribe because the pharmacy thinks about it, and we send patients to the pharmacy. But when the REMS say, as they did at the time of our interviews in 2019, that these have to be dispensed by a clinician in a facility, that creates this feeling that this would be really difficult. And, this logistical hurdle, especially given all of the challenges day to day that we're facing in primary care and all of the competing priorities, to figure out how are we going to order, stock, track, dispense these meds was a bridge too far for this practice. And then the last is leadership support, which Rory also highlighted. And this clinician said, when the perception is that your organization does not care or prioritize providing abortion care, the barriers can be great. So recognizing that it might be doable, but there are barriers. And when you don't feel like your leadership has your back, it's really hard to keep pushing. So summarizing this qualitative research, can you advance the slide? We identified a vicious cycle of barriers, and you can start anywhere you want, but let's start where it says unnecessary regulations imposed. So be it at the state level or the FDA REMS or the Hyde Amendment. Because of those unnecessary regulations, organizations perceive abortion care as particularly complex, despite the safety and relative simplicity of it clinically, especially for anyone who's already doing pregnancy-related care. Given that perceived complexity, organizations fear providing abortion care, and leadership often blocks implementation. Because of that blocking of implementation in everyday practice, abortion becomes and maintains its siloed settings. So places where learners learn, places where people go for the rest of their care, don't, routinely offer abortion care. And because of that, it sort of reinforces this perception of abortion being tainted or undesirable, which then makes it even more politically feasible to impose these unnecessary regulations. Okay, next slide. So the intervention that we came up with, again, pointing to exactly what Rory said about having a team of peers and of coaches to help guide you through this and hold you accountable. We created a learning collaborative, and this is not new. Learning collaboratives, quality improvement collaboratives have been around for lots of things. Perhaps many people in the room have participated in diabetes improvement collaboratives or asthma improvement collaboratives or vaccines. So the basic setup is that researchers or anyone who kind of has that special training or expertise provides the framework for the participants to work together towards a shared goal for evidence-based care. This kind of sharing of the work can take place through in-person meetings, webinars, on-site and distance consultation about specific cases or about how to overcome these logistical hurdles. And then generally there's some sort of a self-assessment about your starting point and a tailored sort of work plan of what you need and are going to implement. So like the staff trainings or the new internal pharmacy processes or med stocking processes, etc. Again, with any learning collaborative, the core elements are that you share a common goal or topic, that you have both coaches and a peer group, and that the organizer of the learning collaborative is creating that forum for interaction. Next slide. So that's what Expand Mifepristone is it's a learning collaborative. It stands for Excellence in Providing Access to New Directions in Mifepristone Use. And what we do is offer these tools. So training, values clarifications, exercises, we tend to focus on the participants in the learning collaborative being kind of those who will implement values clarification in their own clinic. So we focus on it as sort of a train the trainer. And then support for actual clinical protocol development. And then to help advance change in the face of these competing priorities, institutional inertia, and all of these logistical hurdles, we're providing this structured peer support plus individualized coaching. So usually a technical assistance consultant will be meeting with each clinic at least once a month. Another thing is, again, Rory, I feel like you and I are reflecting one another's experiences a lot, is that we recognize that you may get a lot of no before you get a yes, that you may take, 3 steps forward and what feels like 2.5 back, or sometimes 3 or 4 steps back. But by participating together in a group over time, usually these are a year long or 6 months long, you can, the organizers are tracking your change and then helping each group look back and say, okay, here's where we've gotten, here's where we still need to get. And then finally, our approach, we really are committed to researching, evaluating the effectiveness of what we're doing, and also identifying areas where, we are addressing people's barriers and areas where we could be better addressing people's barriers, and disseminating the model through both, academic and clinical venues so that what's working can be scaled up and what's not working can be improved. Next slide. So when we present it to potential participants, we explain that the goal of the program is to move sites forward along the spectrum of evidence-based mifepristone use. And we incorporate both early pregnancy loss or miscarriage and abortion care in our learning. And some of our clinics do not set out with a goal to provide medication abortion. They don't feel that it's feasible. They are facing too much leadership pushback or community pushback, at least perceived. And so they plan to provide early pregnancy loss care, which uses the exact same protocols of mifepristone followed by misoprostol. And what we say is that you don't have to commit to providing abortion care in order to participate, but you will be learning about abortion care. And if you're not going to provide it, the program will instead focus with you on implementing supportive referrals for your patients. And really, this is a term for sort of culture change to make sure that at least you aren't communicating, you're not contributing to barriers, you're not communicating further stigma around abortion or just telling patients, go deal with it on your own. So not everybody will provide abortion, but everybody will learn about how to support their patients who need abortion. Okay, next slide. This is kind of the nuts and bolts of what it looks like, and you can think of each of these as being like 2 to 3 months. So we do this kind of fairly intensive onboarding because each participant is going to get a stipend for participating to offset some of the staff and clinician time. And for some places that will help them buy equipment or buy the initial stock of meds. I encourage folks to identify not just the clinician leads, but the other organizational stakeholders that will be needed to move the process forward. And then the clinic does its own self-assessment and works with the technical assistant to assess where they are and set their work plan, their goals for the year. Then we launch the actual program. Every month the group gathers, and then I'll fast forward through this slide because I want to get to a little bit about what we have found so far. So you can go ahead and I can circle back if people want more details. But the basic idea here is that we are intervening at multiple places on this vicious cycle to try to stop it from reinforcing itself. Next slide. So here's the timeline. We were doing that research in 2018, 2019. We launched in 2020. You may remember there was a little world pandemic going on at that time. So we immediately pivoted from a hybrid idea to being entirely virtual. So now the program since then has been entirely virtual. And we also in 2023 launched a second learning model for the program, which is it's more of a sort of boot camp model. It's 4 to 5 sessions over 2 to 3 months. And we call this the condensed course. For that program, we don't provide a stipend to the clinic, which can be good because it means they don't have to enter into a contract with the University of Chicago to get that. So it's a little bit less barrier to entry. But it also, the condensed course does require more sort of self-motivated learning and homework. Okay, this is where Expand has worked in the past 5 years. So we started in Illinois and the Midwest and have expanded to the whole country. Next slide. And I just wanted to share a little bit of what kind of outcomes we're seeing. We use 3 main methods of evaluating our outcomes. One is patient, like EMR derived data. And this is just in the full year-long learning collaborative where folks are getting that stipend, is that we also ask them to share a limited data set of 2 years worth of patient data for all abortion-seeking patients and miscarriage patients. And this is just one example from a clinic that was able to jointly publish their findings with us. And we can see that this is a clinic that just was implementing MIFI for early pregnancy loss, and their external referrals to OB-GYN for early pregnancy loss dropped significantly. The second means of evaluation that we do is evaluating clinician and clinical staff knowledge and attitudes before and after, as well as self-reported change in practice. So this is our second cohort over on the right. So I think 3 clinics were involved in this survey. And you'll see that there was significant increase in reporting you provided miscarriage care, reporting you provided abortion care, and that you had mifepristone and misoprostol in clinic. We didn't teach to birth control change, so we didn't expect there to be much change there. We sort of ask it almost as a control question. And then last slide for me is our last method of evaluation is that we do mostly clinician and staff interviews at one clinic. So far, we've been able to do patient interviews. So I'll end with these. For the FQHCs that have participated in interviews, this one clinician's quote, I think, is very exemplary or illustrative of how people generally feel, which is that they say, for things that can quite readily and safely be managed in the primary care setting, if we can manage them there, that's where they should be. The patient knows us, they're familiar with coming to our sites, they're always kind of afraid to go to other places where no one knows them, especially on a sensitive topic such as pregnancy loss or the decision to have an elective abortion. So they talk about how it is very values aligned with the clinic in being comprehensive and patient-centered. And then we interviewed from the same clinic where I showed you the decreased referrals, we interviewed patients who had received miscarriage care, but one of the things we asked them about was if your practice was providing the same pills, but for people seeking an abortion, how would you feel about that? And what do you think about, this clinic providing abortion care? And this one patient who was a longstanding patient had her prenatal care at this clinic said, I feel like receiving abortion care from our PCP would be easy, not to have to go and make an appointment with somebody else. You can just go where you choose to. I had to make an appointment elsewhere. And this is, I think, talking about just a general other referral. But she says, I had to wait almost 2 weeks. I left a voicemail. They didn't call me back. But if it was my doctor's office, they would have called back or they would have answered or scheduled an appointment right away. It's just sometimes when it's not where you're used to, where you go to be able to get in there and do stuff. But if it was your actual clinic, it'd be easier. So I will end there and happy to answer questions about Expand when we get to the Q&A. Sorry, I went a little over. Oh, will you go back one slide? We are getting ready to implement a new Expand program for gender affirming care and primary care. So stay tuned for a future talk using this same model on a different topic.
Great. Thank you all for your attention. Again, I'm Anna Fiastro, research scientist in the Department of Family Medicine, and I co-lead the Won't Go Back initiative with Dr. Ying Zhang, who spoke first. And we focus on a lot of the same things, building access to abortion in primary care, but we're based here at the University of Washington, and we have focused more on our region. So next slide. As I mentioned, Ying and I are the co-leads. We also work with Dinah Aldrich, who is our program manager. We also partner with others across the university. So Dr. Sarah Prager in OBGYN, Dr. Emily Godfrey, Ellen Solis in nursing, and Grace Shee. We also partner with outside organizations, RAP, who you heard from Rory, but also the M&A Hotline, which supports patients managing their own abortion at home and abortion on your own terms. We're also supported by the San Simeon Fund and the Washington Department of Health. So so that's who we are. What do we do, or how did we get to where we came, or how did we get to come to be, I should say. So we talked about the fall of Roe and the Dobbs decision in the Supreme Court. And so in 2020, when the decision came, a number of us came together, in part under the leadership of Dr. Ian Bennett, to see what we could do for our patients and in our communities and in our region. We knew that there was going to be some states in our region that had continued access to abortion care and even perhaps improved access, but other states that were going to potentially limit it or severely limit it. So we came together and we formed the Won't Go Back initiative. Next slide. So in July of 2022, we started with conducting a needs assessment. We wanted to talk to primary care providers across our region, the WME region, to see what they were thinking, what they were seeing on the ground, and what they thought their needs would be. And so we leveraged the Practice-Based Research Network, the WPRN, and the Family Medicine Residency Network at the FMRN. And we did surveys and virtual focus group convenings. And the major finding from that was that all participants wished to support their patients in seeking abortion care. There was an overwhelming support for abortion access. Of course, this is biased by those who completed the survey, but still. And they also shared a lot of the barriers. I think we've heard a lot about them, so I won't elaborate, but mifepristone access, federal funding restrictions, and navigating anti-abortion views within their clinics. But they also shared a lot of opportunities. So peer-to-peer learning collaboratives, and regional networks for abortion clinicians. So we had our marching orders. Next slide, please. So we got to work. The first piece that we put together was a peer-to-peer learning program, which was an ECHO program called Expanding Medication Abortion Access in Primary Care. I'll share a little bit more of that. We also developed a regional learning collaborative, as well as one that's university-wide, focused on the University of Washington. And then we're developing an in-person conference for an improved connection and support. So I'm going to go into each one of these solutions now. Next slide. Yeah, so the first one was our ECHO series. And Project ECHO, or ECHO, stands for Extension for Community Healthcare Outcomes. It's a medical education and training model, and it is a 1-hour online session with a 30-minute didactic lesson and a 30-minute case presentation. And it was developed in the University of New Mexico, and is now kind of widely used across healthcare. It kind of mirrors that case presentation learning that clinicians are used to, but adds in the didactic, and has been used in different areas of medicine and evaluated a number of times to be a successful model for education. And we're now in our third cohort. We have our final session next month, so we'll share more information about that, and are planning our 4th year. We found it to be a really great option. Ours is called Expanding Medication Abortion Access in Primary Care Settings. We've landed on an 8-session program, one each month. The didactics are taught by the Won't Go Back team, as well as the UW Family Medicine, Family Planning RAP fellows. And so each year they are brought in to support the development or updating of the materials and then the actual presentation. So that's a great experience for them. And then the case presentations are brought by the ECHO participants. This is a part of kind of a cornerstone of the model, and it's something we continue. And so next slide. We too have evaluated this program in our own setting. We found that participants were mostly white and cis female. They were physicians or physicians in training. They were primarily in Washington State, but also representative of across the country, primarily from academic medical centers, a lot from University of Washington, but also represented FQHCs in our area. And we found that after participating in the program, there was increased knowledge and comfort with medication abortion care. People self-rated their knowledge and comfort in prescribing, and leadership in prescribing, or comfort in taking on leadership roles for prescribing mifepristone within their site were much higher at the end of training. They also appreciated the ECHO model. There was a lot of positive feedback that it was an effective model, well organized, worth their time, and aligned with their personal learning goals. We've had great feedback on that program and are looking forward to continuing it for another year with the support of the Department of Health. Next slide. I'm going to cruise through these graphs. Let's go. It just says that people liked it. One more. There we go. So our second solution was a virtual learning collaborative. This is really similar to what Debbie was just talking about. We partnered with RAP, given that they have a lot of experience in this area. We had national participation. The didactics were done by our team in RAP. And then there was a lot of peer-to-peer learning and support. I think what was most telling, partly due to our recruitment, but also due to interest, where there were a lot of participating sites that were University of Washington primary care sites. It was almost the majority of sites. And so that led us to our second iteration of the learning collaborative, virtual learning collaborative idea, which we call MAB at UW. And this is the university-wide community to support MAB implementation, but also service delivery across the university. And we've had amazing participation from family med, OBGYN, emergency medicine, pediatrics, infectious disease, and internal medicine. We're also collaborating with nursing, the School of Nursing, as well as public health. And so we're hoping that this is less of a finite program with a finite number of sessions and more of the true building of a community here at University of Washington for learners, but also those with more experience and faculty to work together, address evolving shifts in the landscape for MIF person availability, for example, and innovations in care, and do so in a way that everyone can kind of work together and share learning. So that's pretty exciting. If you'd like to join and you're part of the University of Washington, please reach out to anyone on our team or Dinah to add you to our teams and our listserv. Next slide. The final piece that we're working on now, we did another round of a needs assessment after just in the last fall, having had 4 years since our last one, and a lot has changed. So we just wanted to get a sense of where people were at and what they were needing right now. And one of the things that came up a lot was in-person connection. I think we're all coming off the slump of COVID, and while it's challenging to remember how to get together with other people, it seems to be a real need. And so we're developing the Pacific Northwest Regional Reproductive Health and Primary Care Conference, and it's modeled after a successful Southern California conference, also led by folks in partnership with RAP. And this will be hopefully an in-person opportunity for networking, community learning, and sharing lessons learned as well. Next slide. So just one more reminder of what we have right now and coming shortly in the future from the Won't Go Back team. You can still register for the last session of the Medication Abortion Access and Primary Care ECHO on the 11th, or tomorrow, I suppose. And then watch out for future ECHO in cohort 4 beginning next fall. And then also this regional networking meeting or in-person conference that we have coming along. So I will leave it there. Thank you.
Hi, everyone. Again, I'm Latona Giwa with Repro TLC, and I will try to go quick. Ying, feel free to tell me if I just have to stop. So Repro TLC, formerly Midwest Access Project, expands access to sexual and reproductive health care nationwide by filling gaps in training and education. And we have adapted to the changing landscape. You can go next slide, Ying. When Midwest Access Project, as it was initially called, was founded, in part by Dr. Stulberg, who's here today. It was founded in Chicago in 2006, 20 years ago, to address barriers to training specifically for family medicine learners in the Midwest, with the recognition that patients were seeking care in primary care settings, and family medicine providers were struggling with barriers to access to the training so that they could provide that care in their settings. And 20 years later, we have taken that same social justice mission that challenges the idea that abortion care should live on the margins of healthcare, and we have expanded in many ways. We now are training nationwide, not just in the Midwest. We are training providers across provider type, which I'll talk about more, and we're training in abortion care, contraception, pregnancy loss, options counseling, gender affirming care, and beyond, really looking at who and what care is marginalized in this contemporary moment. And the need has only expanded. So in 2004, when this study on the slide was published, it was found that pre the fall of Roe v. Wade, 60% of training needs, so folks who were providers who were reaching out and looking for training in abortion care in this country, 60% of that training need was unmet prior to the fall of Roe. And so here we are post Dobbs decision in 2026, and as has been described, with clinic closures and financial and legal pressures on the abortion care system, that need has only skyrocketed, and more folks are looking for where they can learn this care. I'm not going to go too much into restrictions and barriers. We've talked about that. But one particular thing that we find and face is that because provider learners are in increasingly restrictive environments, folks have to travel farther and stay longer to get training, which makes training coordination much more resource intensive. So it costs a lot more in money and time and logistics to get folks trained today than it did 20 years ago when we started. You can go to the next slide. So our three main programs are our individual clinical training, which is our foundational program, and provider and community education and provider movement building. Briefly, individual clinical training. In this program, we tailor individualized rotations for provider learners. So these could be medical students, residents, physicians, advanced practice clinicians, such as nurse practitioners, midwives, nurses, et cetera, anyone who is interacting with folks, with patients who need sexual and reproductive health care. And we provide individualized training rotations that range from a one-day observation to a 4-week hands-on clinical training at a clinic. We're one of the few organizations in the country that do this type of individualized elective rotation that's opt-in. And we are providing this training, coordinating this training in 23 different partner sites in 16 states around the country. And last year we trained learners from 26 states nationwide. I'm really excited to say that at 20 years, we have crossed the line and of training 5,000 days of individual clinical training for over 500 healthcare professionals. So we have really shaped the present reality of who is providing abortion care today. And then super briefly, provider and community education enables us to reach a wider range of folks with didactic and online education. So doulas and advocates join this training. And then our provider movement building is how we are tapping into our 20 years of training alumni and connecting them to opportunities to advocate and make change in their own communities and advance access to training and care. Next slide. So we do this because it works. So this chart shows that in 2018, when we studied what our training alumni were doing out in communities after their Repro TLC training, we found that almost everyone was providing some type of sexual and reproductive health care, including contraception counseling or pregnancy options counseling. And at least half of our trainees were providing some type of abortion care, which is a huge impact in our communities. You can go to the next slide. You're telling me I have to stop? No.
You can
Okay.
keep going.
Super fast. So we have done a study trying to listen to our providers and provider networks to understand today what is needed. And you can see that folks are still really looking for procedural and medication abortion training. But in this current landscape, they're even lacking access to things like ultrasound training. They are also concerned about legal guidance and digital security and logistical things like working with the pharmacy or insurance to make this care possible. And so we are using partnerships and adapting to be able to meet those needs as well. Next slide. Training the entire care team is something that I believe that we all need to do in this moment to adapt to and frankly survive the hostile environment that we are in sexual and reproductive health care. Folks already talked a bit about why this matters, but we have to bring care to wherever our patients are seeking care and from their trusted care providers. And so Repro TLC has made a commitment to increase resources to training advanced practice clinicians and midwives in our current 5-year strategic plan. And this chart shows how we have been able to increase training to nurse practitioners, nurses, and nurse practitioner students just in the last 2 years in our organization. I will also say that we have been excited to engage in abortion doula training courses and offer those to communities. And we are working with partners to really understand the scope and role possibilities for all types of midwives in this country, not just certified nurse midwives, but also licensed midwives and professional midwives, and where we can provide training to expand their care provision in communities as well. And last, we'll go to the last slide. We'll end with a learner story. So this is Allie. She is an Ohio-based former community organizer who decided to become a registered nurse and then a family nurse practitioner to expand abortion and gender affirming care in her community. And she couldn't access this training in her own clinical program. And so through Repro TLC, she spent several weeks at one of our clinical training sites in Maine, and she got hands-on training in these areas, but she also got so much more. She talked about the impact of seeing compassionate care provision like she'd never seen it before in a setting where patients are recognized as fully human, and the setting was beautiful and friendly. And she left with mentorship relationships and providers who are going to help her implement this care and fight the hostility that she'll certainly face throughout her career. And that is how we're building a legacy of the future of sexual and reproductive health care in our country. Thanks.
Thank you so much to all of you. And thank you for closing us out, Latona. I know we don't have a lot of time, but we want to open it up to questions.
Hey, thank you so much for all the good work you all are doing. It sounds like there are a lot of good ways to kind of protocolize bringing abortion care into primary care settings and training learners to provide this care. I'm wondering if you have thoughts about changing patient perception of where they can receive this care. I think a lot of patients still think they need to go to a Planned Parenthood or an OBGYN special ed. Or do you think it's kind of a, like, if we build it, they will come situation?
Did everyone on Zoom hear the question? Yeah. I'm wondering, Latona, do you have thoughts on this question just with the broad?
Yeah, I would just say one big issue is trust and fear of criminalization, right? So I live in Louisiana, which is a different reality than some other states. And so we are living in a reality where in some states, patients are afraid to go to a care provider to ask about abortion care. And they might go to a community health worker or doula first, who they trust more. And those folks need to be equipped to be able to provide accurate information and referrals, right? And then I would say that part of why we train all types of providers, even if they may not be able to legally do procedural abortion care, is that they can provide that quality information and referral to a provider who can. So whoever the patient is going to, they get what they need to get.
I can add one more thought, which is for some of the expand mifepristone clinics, the sustainability step after providing is clinics' willingness to advertise that they provide abortion care. It's not uncommon to hear, well, we'll offer it if it comes up with our patients, but we don't want to be flooded, which I think is, it depends on your setting, but can be sort of a false fear. You're there, especially if you're a primary care clinic, if you're a family medicine office, you're there to do well child care and to take care of people with their colds and their musculoskeletal issues. And making it known that you offer abortion care is usually not going to take away from all the rest of that. What we have found successful is engaging with other providers in your system. So sort of another version, I think, of what Latona is saying. The ER is a place that is often desperate for places to send people that isn't just a piece of paper or a list, or, go see your OB, which we know a lot of patients that isn't their reality. And so having, for example, like a community health worker or a clinic coordinator do some, hang out in the ED or do some networking with the care coordination team in the ED that are helping patients connect to post-ED care can really help as well.
I know we're at 1 o'clock and I heard there is another meeting coming into this room like right away. So I'm sorry we didn't have more time for questions, but please do send questions to our email. Feel free to find me anywhere in our clinics or on service. I'm happy to answer, but thank you so much for coming.
Thank you all.
Mhm.